I'm Ronnie. Hey, Carly. I see Gina. Hey, Gina. Give everybody a couple minutes to log in before I get started. Hi, Stefania. This is so loud. Hang on. There we go. Hey, Brianna. Hey, Lolly.
Hi, how are you?
All right, it's about 5:33. I'm going to go ahead and get started now. So let me see. Let me just clear a couple things here, and then I'll share my screen with you in 1 second. So we are going to be talking about chapter 8 today. This is on embryology and histology. Can everybody see my screen okay? Very good. So what are we going to be talking about in chapter 8? Well, this starts on page 134, by the way, of your dental assisting textbook. And I just want to remind everybody, I need your cameras on if you're going to be in class. I need to know that you're actually paying attention. It's not just my rule, it's a PIMA rule. So please keep your cameras on unless you really, really can't, if you have reason not to. But what we're going to be doing in chapter 8 is identifying some terms and names of 3 prenatal phases of pregnancy. We are going to describe how the human face develops and changes during the zygote and embryonic phases. We'll identify the life cycle of a tooth, also its stages of development. Identify 4 primary structures of the tooth and location and functions of each. We'll identify the substance of enamel, dentin, cementum, and the pulp and their identifying marks. We'll identify the components of the periodontium and considerations of the alveolar bone. Okay, so let's get started. So embryology is the study of prenatal growth and development processes of an individual. So oral embryology refers to the study of the development of the oral cavity. The first signs of a developing tooth are noted during the embryonic phase in the area that will later become the lower mandibular anterior region. So during the zygote phase, cells rapidly increase in number or proliferate. So they're multiplying at a constant rate, really rapidly. During the embryonic phase, many critical changes are occurring and individual characteristics are being developed. There are 3 stages of differentiation. There's a cytodifferentiation, which is a cell development. There's a histodifferentiation, which is tissue development. And there's morphodifferentiation, which is development of different forms. And during the fetal stage, development continues at a steady pace until delivery. So zygote phase is when everything is rapidly multiplying. Embryology starts to slow down a little bit, and then fetus is sort of through the whole fetus stage, it starts to sort of like slow down a little bit, and it remains constant until birth. So there are 3 embryonic layers. There is the ectoderm, which differentiates into the skin, the hair, the nails, the brain, the nervous system, the lining of the oral cavity, and the enamel of the teeth. The mesoderm, which is the middle layer, that differentiates into the lining of the abdominal cavity, bones, muscles, circulatory system, reproductive system, internal organs, dentin, the cementum, and the pulp of the tooth. The endoderm is the middle portion, or the very center of the embryonic layer. That differentiates into the epithelial lining of the respiratory system, the glandular organs, and the digestive tract. So there are primitive facial developments. So the face begins to form in week 4 and further develops into 3 embryonic layers. The facial development continues until about week 12 of pregnancy. The first area, or the frontal nasal process, is the upper portion of the face where the forehead, the eyes, and the philtrum are formed. So everything above the philtrum is a frontal nasal process. The second area is the maxillary process. This is the middle portion of the face where the cheeks, the sides of the upper lip, the mid-face, and the secondary palate, the zygomatic bones, which is the cheekbones, the portion of the temporal bones, and the maxilla embryonic surface are developed. The third area, the mandibular, is the lower portion of the face where the mandibular arches, the lower lip, the lower face, the temporal area, and the mandible are formed. And just a side note, the stomaderm, which is the primitive mouth, develops between the maxillary and the mandibular processes. Initially, it looks like a shallow depression in the embryonic surface, and then gradually develops after that. So after only about 2 months, all the body organs have been formed. The tooth buds begin to appear about week 11. The oral and nasal cavities begin separating during week 12. And then during the first trimester, the first sign usually is a missed period. Okay, the breasts will swell, become tender, the nipples enlarge, preparing for breastfeeding. Nausea and vomiting are also common. Weight gain is usual after vomiting period ends. And then on average, weight increases during pregnancy. Weight increase during pregnancy is about 28 pounds, give or take. The mother's heartbeat will increase to pump more blood to the fetus around this time. During the second trimester, routine ultrasounds are done. This test can estimate delivery date, multiple fetuses, or fetal malformation. And this test can also show the sex of the child. During the third trimester, the woman may experience stretch marks, hot flashes, and perspire easily. The fetus matures and his head starts to tip down, preparing for birth. This relieves pain from the chest region to the mother, and but it also puts additional pressure on the bladder and hip region, which makes you want to pee a lot, I guess. Look at me schooling you on pregnancy. I'm sure you're all like, Mike, if you only really knew. So let's see, let's go on to the next stage. So drugs and infections can initiate malformation in the unborn child. So women who have continued to use alcohol during pregnancy may exhibit fetal alcohol syndrome. So some of the most common syndromes of FAS include small head circumference, low nasal bridge, an indistinct philtrum. Remember, the philtrum is this kind of folded part above the lip, a thin upper lip, and a small mandible. Dental professionals should be involved in with these children and help them with problems that could limit nursing and feeding. Adjustments need to be made to allow proper nutrition care for the child. Another issue with tissues not fusing properly could mean the teeth will not erupt properly. So reconstructive surgery and speech or hearing therapy may be needed unfortunately, with fetuses or babies with fetal alcohol syndrome. The cleft lip occurs when the process of diffusion fails with the medial nasal. The cleft uvula is the mildest form of cleft palate because it does not hamper eating or speaking to the same degree that a cleft palate or a cleft lip would. The clefts could be bilateral and only the posterior palate. You may also see a complete unilateral cleft lip and alveolar process with unilateral cleft or the primary palates. So a cleft uvula, remember the dangly thing in the back of our throat? That's the mildest form of a cleft palate. So it's not really that big of a deal. It just looks like the uvula is split into two. So that is the mildest form. A cleft palate, in this case, is the failure of the palatal shelves to fuse with the primary palate of each other. So we have this palatal suture that never really forms, and then the palatine bones never really fuse together. So we usually have the nasal septum that is exposed, that is usually exposing the sinuses and all that stuff. So cleft palate is would be the next, I guess, more severe form, but it's not the most severe. Okay, the next one is a unilateral cleft lip, a primary palate and alveolar process. So here we have the philtrum that is usually kind of diverged to one side, and then the lip never fuses. We have a primary palate, the alveolar process, and the secondary palate. With the unilateral cleft palate, it's usually only split on one side, so it's not really symmetrical. Okay, the next stage would be a cleft lip and palate, where we have a bilateral cleft lip, alveolar process, and primary palate, where we have this opening sort of on both sides. And then a bilateral cleft of lip or alveolar process, and primary and secondary palate is when we have the bilateral cleft lip. So both sides don't fuse, and then also the palatine bones on the palate don't fuse. So that would be the most severe form. So although hereditary factors can play a role in normal fusion, it is important for mothers to enjoy good nutrition and stay healthy to avoid these sorts of complications. Cleft lip occurs in about 1 in 1,000 births, so it's more common and severe in boys than girls. Just some food for thought. Okay. So what do you think can be hampered in a patient who has cleft palate, especially during the first stages of birth, after the newborn is born? What do the fetuses, or not fetuses, they're babies now. What do babies do with their mouths in the beginning of life?
Breastfeed.
They eat, yeah.
Brittany, any guesses? What do babies do?
Bree and I both answered. Can you hear us?
Can you hear me?
Can you hear us, Mike?
I can't hear you.
Mike, can you hear them? There's something wrong with your audio.
Okay. Sorry, I had my volume off. Okay. I was like, why isn't anybody saying anything? Okay. Can you say that one more time?
We both said, well, Bree said breastfeeding, but I said eating, same thing, but
Right. They need to feed, right? So thank you. Thank you for that, Brittany and Brianna, for that tip. That there's something wrong with my audio, obviously. So yes, eating and speaking. So if babies have a cleft lip, they can't latch on, right, to any source of food. And then also once they start getting to that age where they need to speak, they're going to have a hard time speaking. And so those can be definitely a detriment as they begin childhood. Good, thank you. All right, so histology is the study of microscopic structures and the functions of tissues. Oral histology is the study of the tissues of the teeth and the structures of the oral cavity that surround the teeth. So we have the stages, the tissues, and the structures. Initiation takes place in the bud stage. So we're talking about the life cycle of the tooth. So this is when the tooth begins formation from the dental lamina. 10 growths on each arch appear and later become the primary teeth. So we have 10 growths. Babies have 10 teeth on each arch. And that begins with the dental lamina. The 6-year molar begins developing at birth. Okay, so it's already developing at birth, even though we don't see it until about age 6 in the mouth. The 12-year molar starts developing when the baby is approximately 6 months old. Okay, and then the wisdom teeth begin growing at about 5 years of age. So during the cap stage, the bud begins to grow and changes shape. So this is proliferation. Proliferation takes place as the cells multiply and develop into different tissues. The dental sac is then formed, which will further develop into the dentum, the cementum, and then the pulp of the tooth. The bell stage is the histodifferentiation and morphodifferentiation, where the crown starts to appear and it starts to take shape into what the teeth are, into what we know what the teeth are supposed to look like now. So the maturation stage is the final stage where odontogenesis reaches completion. So odontogenesis is a fancy name for the birth of a tooth. All of these tissues have been fused in the appropriate manner at this stage. So throughout apposition, the salts and minerals have all developed or have been deposited into the tooth of the enamel, the dentum, and the cementum. So that's when all of these things have been formed. The layers of the tooth become calcified, and the tooth finally emerges through the gum tissue in the eruption phase. The tooth is now visibly seeing in the eruption stage. Attrition is where the tooth wears away, usually at the incisal edge or occlusal surfaces, if we're talking about posterior teeth, during the normal function and use. Okay, so the maturation stage first is apposition, and then calcification. Calcification is just where all the minerals and salts get deposited into the tooth. Eruption is when the tooth comes out of gum tissue and we actually see it. And then attrition is just wearing away from natural or from normal use. So there are 4 primary structures of the tooth. We have the enamel, which is a structure that covers the crown of the tooth. It is the hardest living tissue in the body. The dentin makes up most of the tooth structure and is not normally visible unless the patient's like 60 or 70 years old and they have lots of wear, or they've been sucking on lemons their whole life and their enamel is all worn away. Then we start to see the yellowing of their teeth, which is just the natural color of the dentin, which is sort of the middle of the tooth. The cementum is located around the root. So it covers the dentin on the root portion of the tooth. The pulp is a tissue formed at the center of the tooth, and it's made up of nerves and blood vessels that provide nutrients to the tooth. It also provides sensation, and it's the pulp that ends up giving us a toothache if there's like decay or something that reaches the pulp and it becomes inflamed. That's when we have things called pulpitis. Those are what gives us the throbbing toothaches. If you've ever had one, it's not fun. Okay, so now we have, so here is the tissues of the tooth. Again, the enamel is the outside covering of the crown. It's the hardest substance in the body. We have our dentin, which is basically the middle portion of the tooth. It's called dentin if it's underneath the enamel. If it's underneath the root portion, we call that, well, it's also called dentin, but around this part here, the outside edge is the cementum. The pulp chamber is the middle of the very middle of the tooth. This is where all the nerves and the blood vessels live. The pulp canal goes all the way down the roots of the tooth. And then, so without dentin and pulp, the enamel can become really brittle. So when we do a root canal, we basically remove all of this nerve tissue from the center of the tooth all the way down the roots of the tooth. So we take all that out and we fill it with some sort of like rubber synthetic material called gutta percha. And so that basically replaces this hollow area. So what happens is because all of these blood vessels and nerves are removed, it basically robs the tooth of all its nutrients that it needs. And so after that, the enamel and the dentin become very brittle. And without a crown, something that basically replaces this enamel, the tooth becomes very brittle and it's prone to breaking. So anybody who's ever had a root canal, if you don't get a crown on it, you're likely to lose that tooth due to breakage in the near future. So we have the enamel. There's a process called Tome's process. This guides the enamel matrix into place. As a secondary layer is laid down, the first becomes more mineralized. So we have these enamel rods, which are made up of the head and the tail. And as these are laid down, the next layer becomes, or the layer before that becomes more mineralized. So it becomes stronger. Every time an enamel rod is laid down on top of each other, the layer before that becomes stronger. And so because of the way these are shaped and the process by which the bottom layer hardens, this is why the enamel is the strongest structure in the mouth. Okay, it's just the way it's formed and the processes of the structure of how it's formed. Okay, under a microscope, we see many different incremental lines, ridges, and grooves around the layers, much like the growths of the rings of a tree. So some indicate the trauma that has taken place, if there is any trauma. So we have lines of, sorry, there's a fly around here. Lines of Retzius, which we have, some of it are called neonatal. We have imbrication lines and perichymata lines. We have enamel spindles, which are enamel tufts, and also made up of enamel lamellae. Okay, these aren't anything that you really need to know for any tests, just something that's covered in the lecture. So it will cover more, the book will talk a little bit more in depth into this if you're interested in it. But I'm guessing not a lot of people are really interested in the microscopic layers of enamel. So I will move on. So we do have some enamel disorders that are possible. So enamel dysplasia is a grooved and pitted teeth due to malnutrition. So if somebody doesn't have enough malnutrition, they get sort of like this mottled enamel look. And sometimes and it looks almost like decalcification, like chalkiness of the enamel. And so sometimes if it gets bad enough, as restorative work might be necessary, either because it's structurally unsound, or for aesthetic reasons. So if we have this mottled chalky enamel on the front teeth, you might notice some people have that. They might want to get it fixed just due to that. So dentin has this natural yellowish undertone, and it has this fluid that passes through tubules. You can think of tubules like pores in your skin, and they're like, what they are actually little micro canals that go from the pulp of the tooth, and then they feed all of the tissues of the dentin basically. And so that goes through tubules. We have developmental marks like, let's see, developmental marks can be thought of like dentinal hypersensitivity, imbrication lines of von Ebner, contour lines of Owen, and then the neonatal line. So if you have hypersensitivity in your dentin, This is where the dentin is exposed because of these developmental marks. It can be very painful, very sensitive because the dentin is filled with all of these tubules. Remember, these tubules are like little channels that go down into the pulp chamber. It can feel almost like the tooth is exposed. And so if you were to use like an air water syringe without anesthesia, it can cause your patient a lot of discomfort. So developmental marks are also apparent in dentin, as with enamel. A disturbance in a person's metabolism can leave noticeable stained lines, but the most pronounced is a neonatal line that occurs with trauma at birth. Okay, so these are just some of the developmental marks of the dentin. So we have dentin. Dentin is not really uniform. It changes throughout the tooth. Okay, so we have different layers of it. We have peritubular dentin, which is the dentin that creates the wall of the dentinal tubule. We have intertubule dentin, which is found between the tubules. The mantle is the first predentin that is formed and then matures within the tooth. The primary forms the bulk. The circumpulpal dentin is sort of the layer that surrounds the pulp of the tooth. The secondary forms after the completion of the apical foramen. So the apical foramen is at the very bottom of the tooth of the root. We have this hole. Remember, foramen means a hole, or specifically a hole where nerves and blood vessels run through. So the apical foramen would be naturally at the apex of the tooth. And so, let me see, where was I? There we go. Where was I? Okay, so the secondary forms around the completion of the apical foramen and then slowly throughout the life of the tooth. The tertiary dentin repairs and is reactive to irritants. So if you have a cavity and it starts to get close to the pulp, let me go back to the slide here. So we have a cavity here in this area and it starts to get close to the pulp. That, sorry, losing my train of thought here. That tertiary dentin will actually lay more dentin around the pulp, which will basically cause the pulp chamber to collapse. And what it sort of does is it makes the pulp chamber run away from the cavity. So oftentimes when you have somebody that had a cavity and they don't get it repaired right away, if they're lucky enough, that tertiary dentin will lay more dentin, basically trying to cover up the pulp chamber to get the pulp chamber to basically run away from the cavity or whatever trauma is being caused to the tooth. So that is like your body's natural way of, I guess, making a root canal. So that's why sometimes, like, especially when we get older, our pulp chamber starts to shrink. That's not just from cavities. Okay, this is from trauma, just from using our teeth, from chewing, for biting on things. As we get older, our pulp chamber starts to shrink. It gets smaller and smaller and smaller. So this is why when we're really young, our pulp chambers are usually huge. So anything is basically prone to make our teeth really sensitive. As we get older, our teeth aren't as sensitive because that pulp chamber has shrunken down, and there's a lot of that tertiary dentin that's kind of being put between the enamel or the outside environment and the pulp chamber. Okay, so enough of that. So now talking about the pulp itself, the pulp is made partially from fibroblasts and partially from intercellular substances. The fibroblasts synthesize protein fibers while the intercellular processes form the pulp tissue. The pulp is fed continually through the opening of the apex of the root, which is the apical foramen. The pulp supports nourishment and maintains the dentin. The pulp sends messages to the brain when nerves have been injured, working as sort of a warning system, defending the permanent damage from the tooth. So it's like sensation for your tooth. For the same reason we have sensation in our hand that tells our hand, ouch, there's a hot pan or there's a hot iron there, move your hand away. So for that same reason, we have sensation in our teeth, so that if we're biting on something that we shouldn't be biting on, or using our teeth for tools and that sort of thing, sends a message to our brain to tell ourselves, okay, ouch, don't do that. Stop biting on that hard substance. You're going to break your teeth. If you break your teeth, you can't really eat well. So it's our body's natural form of survival. Okay, so in the pulp, we can get things like pulp stones. Okay, so these are calcified masses of dentin that are they kind of get laid down in the middle of the pulp chamber. Those are very common. There's nothing really wrong with them. There's nothing much to say about them other than they can be there sometimes, and it's something that you'll see in an X-ray. They don't cause any sensitivity, and there's no reason to go and try to repair it. There's really nothing to repair. So who could tell me what a patient might experience if the dentin is exposed? I have my audio on, I promise.
Sensitivity.
Right, sensitivity. And so that dental, we call it hypersensitivity because sometimes it can be very painful. So I sort of tell patients it's sort of like if your tooth has no jacket and you're really cold, except it's worse than that because it can actually be painful, not just cold. Anybody's ever had a crown done? Oh, you're lucky. Okay, sometimes when they're doing a crown, they always numb you for that. And then they shave away basically all the enamel away from the tooth. And then sometimes, especially if we're doing like same day crowns, that patient is sitting there in the chair for about an hour, sometimes 2 hours while the crown is being made. During that time, it's common sometimes for that anesthetic to wear off. And so they'll experience this hypersensitivity because there's no more enamel. So if you work in an office that does same day crowns, and I'm thinking that a lot of you may, since it's becoming more and more common, it's important to check on your patient, make sure that they're still numb throughout that process, because when their tooth has no enamel on it and the sensation starts to come back, any type of, even if they open their mouth like to talk, the air from the environment can hit it and it can be painful, not to mention when you have to go and cement like the crown on top of the tooth, which is very acidic. That in and of itself can be very painful, especially if you have to use water or air. So it's just something to kind of know. There's no enamel on the tooth. It's it can be very painful because of that hypersensitivity. Okay, so the cementum surrounds the tooth and the root, and attaches to it at the alveolar bone, so right at the bone that holds the tooth in, by anchoring ligaments. So around, let's see, in between the tooth and this pink part here is bone, okay? We have these little ligaments, they're kind of like shock absorbers that kind of anchor the tooth in. So those shock absorbers are connected to the cementum of the tooth. So because it needs to connect to these periodontal ligaments, it's softer than both enamel and dentin because it's more porous. Because cementum does not resorb and regenerate like bone, it allows for orthodontic movement to move the teeth through the bone and not destroy the cementum. So this is why we're able to move teeth with orthodontia. We have something called Sharpie's fibers that act as anchors between the alveolar bone and the tooth. So these are sort of like part of the periodontal ligaments. It's just a more fibrous tissue that allows for more solid attachment to the tooth. So we have the mandible and maxilla bones, which are formed by osteoblasts, which are cells that, osteoblasts are cells that allow the bone to form. And then we have osteoclasts, which basically break down the bone. So as, let's say, for example, we're going through braces or orthodontia, we have a bone that has these little ligaments, we have a tooth that's set into bone and there's little ligaments on either side. Okay, so let's say we want the tooth to move that way. So we have osteoclasts on this side, which are basically destroying bone so that the tooth can move this way. And then we have osteoblasts on this side, which are causing bone to form. So that's basically keeping that tooth stable. So osteoclasts remove bone, osteoblasts set bone in place. The alveolar process contains the extended areas of the bone and each arch that are tooth bearing. So when the two cortical plates come together, so with bones on the palate, between each tooth, these are called alveolar crests. Because the bone does not regenerate, if diseased tissue is found, it must be removed. Modern implants are more successful if proper hygiene is maintained. So there's some alveolar bone disorders, some clinical concerns like the periodontal disease, which can cause bone loss. Implants are an option if teeth are removed. But again, if a patient has active periodontal disease, which is the bacteria that causes the bone loss, and it's not taken care of, sometimes these implants can fail, much the same way that the original tooth failed. So periodontal disease must be taken care of either way, whether it's sooner or later. It really depends on if you want to keep your teeth or not, or if you're going to invest $5,000 into an implant to replace one tooth, you want to have it kept at bay so that it doesn't destroy that restoration as well. Okay, like all connective tissues, fibroblast cells from the periodontal ligament, which secures the tooth into place using organized fiber groups, must be kept healthy. So periodontal disease can destroy all of these fibrous tissues. So there are two types of fiber groups. We have the periodontal and the gingival. The gingival fiber groups would be on top. Periodontal ligaments would be on the bottom. Okay, we don't need to talk about periodontal fiber groups very much. It's just the way the different fibers are connected, the different directions that they go. So I'm going to skip that one. Let's see. That one too, we don't really need to know too much about that. I'm going to skip that one. So gingiva, this one is important. This is also known as gums. So if you don't know by now, anytime I talk about gingiva, I'm talking about your gums. So, gingiva have different texture and color depending on somebody's race. Some clinical considerations to keep in mind are gums can do things like gingival hyperplasia, which is the overgrowth of gum tissue where they can appear red and swollen. They can usually be treated with better hygiene, but that's how you know somebody has gingivitis, is when their gum tissue becomes very swollen or red. It can be puffy, they can be bleeding, they can be painful. So although different pigmentations of a person can be a factor, the color is usually pink to red, but we don't want it like a crimson red, right? Because that's usually an indication of inflammation. And then gingival hyperplasia can follow after that. So here we have some diagrams of the gingiva. We have the alveolar mucosa, which flows into the tissue of the cheeks, the lips, and the inside floor of the mandible, and appears loosely attached. Okay, we're talking about this area here. We have the mucogingival junction, which is the line between the attached gingiva and the alveolar mucosa. So basically this line here, that kind of differentiates the attached gingiva, which is attached to the tooth, and the alveolar mucosa, which is sort of when it starts transitioning into the inside of your cheek. We have the attached gingiva, which extends from the mucogingival junction into the gingival grooves. Tissue is attached tightly around these areas. We have the interdental gingiva, which is an extension of the unattached gingiva between the adjacent teeth. So these little extensions here are the interdental gingiva. The marginal gingiva surrounds the teeth, right? This is sort of this kind of C shape here. And then the gingival groove is the line of demarcation between the attached gingiva and the marginal gingiva. All right. So what condition is characterized by the thickening of cementum around the apex of the tooth? Who can tell me?
Hypercementosis.
Very good, hypercementosis. Right, so that's when the cementum around the apex of the tooth thickens, which is, excuse me, here I'm chewing on nuts and I'm getting choking on them. So it's when the cementum around the apex of the tooth sort of gets enlarged. And it's usually because of like bad hygiene, can also be genetic factors involved. But there usually isn't much we can do about that. Okay, so that is pretty much it that I have for chapter 8. Let's see, what time is it? Okay, so very quickly, I'm gonna stop this share so I can kind of show you what I want to show you next. Okay. Boom, okay. All right, so here is our course content. We're gonna go into today's folder. Today's Wednesday, right? Got it. Okay, so what I want to show you is this assignment here, the anatomic charting quiz number 1. Can you all see that okay? I just want to make sure that I'm sharing my screen. Okay, you guys can see my screen, right? Cool. Okay. So we have this blank anatomic chart. So you're going to use this chart and you're going to use red and blue color pencils, markers, crayons, whatever you have, but some type of red and blue ink. And so let me just go ahead and open it here. Actually, where is the one that I wanted to show you? Oh, here it is. So up here we have a study key. So this is, I'm going to open this one first because this is actually shows you what I want you to do. So I wonder if I can. Yes, that's right. So we have, and we went through some of this geometric charting in the past, and I think I might have even touched on the anatomic stuff. The geometric one, remember one was with charts with little circles, and I told you, like if you want to see a mesial cavity, it's like on the one side of the circle, the distal is on the other side of the circle. Well, that was a geometric chart, and what we have here is an anatomic chart. So depending on whatever charting system your office has, you're going to see one or the other. Sometimes charting systems use 2 of them put together. So this one happens to be anatomic. And so what you're going to do is you have something that looks like this. So something with a blue ink is usually means conditions. For purposes of this class, we're going to say that blue means a condition. And this isn't always set in stone. Every office has different colors for whatever, but usually blue is existing conditions. So something that has a circle around it would mean that the tooth is impacted. It's there, but it's just, we can't see it in the mouth. It's impacted in the bone somewhere. Okay, if we see a solid mark here, so this is a filling. And there's 2 ways to go about drawing this mark. I don't really like the way this one is drawn in just because it kind of, it's kind of deceiving a little bit. So this is a DO amalgam. And what we see here is the reason I know it's a DO amalgam is because we see an amalgam here in the center and then also on the distal portion here. What I kind of prefer, and you might even prefer it too, because it's more clear, instead of marking the distal portion here, I would just extend this circle up to the distal portion on the occlusal surface, because we know that in order to fix a DO cavity, we actually need to drill away all this area here, all the way up to the distal surface. And you can even put that one there if your heart really desires. But that is just one way of marking a distal occlusal amalgam. Okay, here we see, who can guess what this is?
Is that mesial or is that occlusal? Mesial-occlusal distal?
Very good. So a mesial occlusal distal, and the way Marquita was able to differentiate that is, yes, we do see an occlusal portion here, but we also see the mesial section that has a filling, and also the distal portion that has a filling. What I prefer, though, is if you were to kind of make this sort of like an H, right? So we have this here, and it would encompass the distal portion, the occlusal portion, and then also the mesial portion. It just makes it clearer. That's what you would normally see in like a computer aided charting database, as you would see a sort of an H shape. I don't think I've ever really seen anything like this on a computer part, although this is acceptable, especially for like old-fashioned charting. So that would be a good MOD, okay? Then what we have here, this is sort of just has a shaded portion here. It's not filled in. So what this actually is a composite filling. So what we have is a facial mesial or mesial facial composite. Okay, so that's what that would look like. And if you remember your classifications, you know that this will be a class 3 filling, right? Because it encompasses the proximal surface, which is the in-between surfaces of the teeth, and then also just the facial. So anytime it encompasses the distal or mesial, it's class 3. This one here also has, it includes the incisal surface. So this would be a class 4. You don't need to know this for this, you don't need to know the classifications for this assignment, but I just want to kind of go over it over and over so that you can kind of be more familiar with what these look like. Okay, this one here is in red. Who remembers what red stands for?
Needs treatment.
It needs treatment, right? So this patient has some type of cavity on the mesial surface. And so we would usually do a mesial facial in that regard, because we can't get a drill bit or a burr to get in between the teeth without destroying either the facial surface, or the lingual surface. So depending on if it's closer to the facial or closer to the lingual, the dentist would decide if it's going to be a mesial facial or a mesial lingual. Okay, so what we see here is we have anytime we see roots that have lines on it, it kind of reminds us of like the threads on a screw, or you can think of it that way. And then an X on top means that there is no tooth there. So anytime you see an X, it's a condition that the tooth is no longer there. Or if it's red, it means that the tooth needs to no longer be there. Okay, so there's no tooth here. And we also see the root portion that has little lines on it, which indicates it's a screw. So this is actually an implant. The implant has not been restored yet, meaning there's just the implant on the bone that's healing. And eventually we need to put a crown on it so that we complete the whole implant process and it actually looks like a tooth now. Okay, so this implant is already completed, but the red part indicates that it needs usually if it has a line around it and there's not filled in, that indicates the need for a porcelain crown on top. Okay, this blue line here represents an existing porcelain crown. Again, this is another MOD. And if you notice here, you can't really see it too much on this picture here, but there's actually a red line around this tooth. And that indicates that, yes, there is an MOD amalgam there. but perhaps it's failing or it's leaking and it needs to be replaced with a new filling like an MOD, composite. Okay, here we have another filling. It's an amalgam filling that needs an MO. Here we have an X, right, which indicates the tooth is no longer there. And that means something I don't recognize what this arrow means, but I'll find out in just a minute when I look at the key. This bottom one here means that the tooth is impacted, but for whatever reason, sometimes it's coming in at an angle. So it's going to start affecting tooth number 18 here if it's not removed. So the dentist wants it to be extracted. So either one line is okay, or you can put 2 lines in the X if that makes you feel more comfortable, but this tooth needs to be extracted. Who can guess what this is?
A bridge?
Yes, how did you know it was a bridge?
I just remember you telling me that the lines were gold caps and then the tooth in the middle is missing.
Right, so we have a tooth here that's missing. And what a bridge is, we have one crown on either side. So it's one post of the bridge, the other crown on the other side is the other post of a bridge. And we're thinking about, or if you can think about the bridge that we would drive on to cross an ocean. The pontic is the fake tooth in the middle, which was the road that we would drive on, because there's nothing underneath here because this tooth is no longer there. So these diagonal lines indicate the fact that it's we're looking at gold here. And so it's funny that this has porcelain on the facial surface. It's probably because it kind of it's in the patient's smile line. So that patient probably didn't want gold to be in the front. So the back sides of this crown is made out of gold, and they probably put like they probably laid down like porcelain in the facial portions of these teeth here, just so that it looks a little bit more aesthetic. Okay, so here we have, I believe this is a lingual bar retainer, and the lingual sides of the front teeth on the bottom. Here we have an existing root canal. We know that because it's a line drawn down where the root canal would be, a blue line which indicates an existing root canal. And then here we have a porcelain fused to gold crown that is needed. Remember when I said anytime a tooth has been root canaled, it needs to have a crown on it if we want to keep that tooth. Otherwise, what happens?
Tooth dies and
Yes.
it turns black.
The tooth dies, it becomes black, it becomes brittle. So at any moment, if a patient does not put a crown on top of it, they can bite into a peanut or something, and that whole tooth will kind of just shatter, okay, because it's very brittle without its nerve and its innervation and its blood supply there. This sort of bubble that we draw on the tip of the root indicates an abscess formation. So this is an abscess that we see there that needs treatment. So who knows what an abscess is or results from?
Doesn't it result from like an untreated cavity?
Right. So if you have a cavity that is not treated, eventually it will infect the nerve. And that nerve is basically a tunnel or a communication passage to the bone around there. So when we see an abscess at the root of the tooth, it's actually because the bone has been infected. So that's an infection in the bone, and the only way we get rid of that is either to remove the tooth or remove the source of infection, which is through the nerve. So this tooth here, tooth number 29, would need a root canal. And if we have the root canal, it needs a what?
A crown.
It needs a crown. Very good. Okay, so tooth number 30 is this molar here. It's our first molar. We see a solid red dot on the occlusal portion of that tooth. A solid anything indicates some sort of metal. So this is going to be an amalgam filling that is needed. Or it can also mean an inlay, like a porcelain inlay. I don't know why any doctor would want to do an amalgam filling in the 21st century, but sometimes they do, especially if we're dealing with access offices, unfortunately. So either it can be, and you have to really think of the context. If your office is doing porcelain inlays, it would most likely be an occlusal inlay. If you're working in an office that deals with state insurances like access, then it's probably obligated to do some sort of amalgam filling, unfortunately. So that would be an amalgam filling that's needed, okay, in the occlusal section. Here, again, this is going to be an MO, right? Because it's encompassing the mesial portion and the occlusal portion. And then this section of the tooth is missing. Okay, so that covers whatever sort of like a key or a reference guide that you can look at for this assignment. So I'm going to go back to this screen here. So if you kind of forgot about the things that we just talked about, so that was the anatomical chart. This next document down here is an explanation for the anatomical chart. So that is the key for this. I'm going to go ahead and open that. Ta-da. Okay. So this just kind of goes over what each demarcation means on that key. So it goes from number 1 all the way to the number 32. So it should go in line with what I was basically talking about so far. So this is sort of like an example or a reference guide that you can use to sort of explain the charting assignment for tonight. So the actual charting assignment for tonight, you're going to get a blank anatomic chart. Nope, sorry, wrong one. Blank anatomic chart. There you are. So you're going to get something like this, right? That has a blank anatomic chart. It's also got a treatment plan on the bottom. So what you're going to do is you're going to get this, open up this anatomic charting quiz. Ta-da. And so it's going to give you some things to put in there. So depending on whether it needs it or it has it, you're going to use a blue marker color pencil or a red marker color pencil. So for example, number 1 is impacted and needs to be extracted. What would we draw on tooth number 1?
A circle.
What color circle?
Blue.
Blue circle. And then what else?
And then the red line through it.
And a red line through it, correct. And because we know that there is a red line or some type of red marking on that tooth, down here in the bottom, we would also indicate what it is that tooth needs for clarity. So tooth number 1 would need an extraction. You would just write it here in this treatment plan part. Okay. Don't want you to do that part yet for right now. I just want you to chart it, but that just kind of gives you kind of a segue into the next part of the assignment. So you're going to go through this entire chart using this anatomic charting quiz from 1 and all the way, like 3 has an existing gold crown. Gold crowns have a diagonal line, so it would be blue diagonal lines. Number 5 has an existing RCT and porcelain crown, so those should all be blue. Number 7 has a distal facial caries, right? So that is going to need some type of treatment. Number 8 has a mesial incisal fracture. FX, by the way, means a fracture. So that's going to need some type of treatment. Number 9 has an implant with the porcelain crown. That's blue, already done, already taken care of. Doesn't need anything else. Number 13 has an occlusal composite. Number 14 has an MOD amalgam. Number 16 is missing, so all these things will be blue. Number 17 is impacted and needs to be extracted. So again, that one's going to have a blue line, blue circle, and then a red cross going through it. Okay, so once you're done with this, you're going to go to the treatment plan exercise, and you're going to use basically that same chart. Go ahead and open this here. Right? So you're going to, let me see if I can put these together so we can see both of them at the same time. So you notice here there is a tooth number 1, right? Because number 1 needed something. There's a tooth number 7 because number 7 needed something. And if you notice, there is 3 tooth number 7s. The reason why there's 3 tooth number 7s is because we have different options that we can do. So number 7 has a distal facial cavity. So we can either do a distal facial composite, we can do a veneer, or we can do a crown. So those are options that we would normally give a patient. We would explain to them that we can either just patch up that cavity, and that cavity, that composite might last 5-7 years before it starts to leak and starts to need to be repaired. We can put a veneer around it, or we can just bite the bullet now, do something really permanent, and do like a crown on number 7. Okay, the same thing you would do for number 8. Number 8 has a mesial incisal fracture. So we can do a mesial incisal composite, we can do a veneer, or we can do a crown. So those are the reasons why we have multiple teeth here. Here we have number 28. So number 28 is abscess. It needs an RCT and it needs a porcelain crown. So number 28 can be an RCT, a porcelain crown, or we can extract number 28, right? Because it's infected, we got to get rid of it if they don't want to do that. Or we can do an extraction and an implant. So if it has an implant, we need to do like, that's going to be the third option. Number 28 needs to be extracted. We need to place an implant and we need to place a crown on top of the implant. Okay. Any questions with that assignment? Kind of a curveball, I know, but this is how we basically treat implant teeth.
I have a question.
Uh-huh.
How are we supposed to color the teeth? Like, did you want us to print it out and like take a picture or?
Yeah, you'll need to print it out. And that, I realize that some people may have some issues with printers. Let me think. If you have,
Maybe you could do like paint or something, you know, like where you can do paint on the computer.
yeah, that if you have some sort of like paint program, like what Bree was saying, is you can bring it up on your computer and then use your paint program, turn it into a PDF, and then turn it in that way. If you have problems printing it, so that would be a good idea. If you don't have, like, if you don't have a paint program, if you don't have a printer that works, what you'll need to do is you'll need to actually draw these out on a piece of paper. Draw all these little teeth here as best you can, and you'll have to color it in, and then take a picture of it and turn it in that way. Okay, but I need something from you that demonstrates that you know how to chart, basically.
You are not going to know what it is if I have to draw those teeth.
I'll get the idea. If you can read my writing, I can read your writing or your drawing. My drawing is terrible. So even if they're just little ovals that have little roots drawn onto them, that's fine. You don't have to be like precise. You don't got to put all the little anatomy in there. Even if they're just ovals, but I need to know that you know how to chart, basically. Okay.
I'm sorry, Mike, I missed it. What should we do then if we don't have the paint application or a printer?
So you'll need to draw these teeth out like on a blank sheet of paper, and sort of like what Brittany's saying, if your drawing skills aren't as good as mine, okay, we all know my drawing is terrible. You can just simply draw little ovals, right? And then little portions of the roots. It doesn't have to be pretty, but I need to know that you know how to put the charting symbols on those ovals. Does that make sense? Okay, and then you can either do it on a separate sheet of paper, or you can make little, like, leave space on that same sheet of paper to put the treatment plan. The treatment plan is going to look something like this here, but you just have to make sure that these teeth, these teeth that are here are the ones that need treatment, and so you need to put some type of treatment. And like number 7 is laid down 3 times. That's because there's 3 different options that we can do. Same thing with number 8 And same thing with number 28. There's 3 different options that we can do. Okay. Any questions with that? Or any other questions? Make sure someone's trying to ask me something. Okay. Sorry, I don't mean to make you dizzy with my screen going back and forth, but just want to make sure I'm covering everything. And then after that, we just have some quick check assignments for chapter 8. And it's just basically just one, the muscles of facial expressions. So make sure you get that, because there is going to be a quiz tomorrow on the muscles of facial expressions. Today we have the facial bones test. That one's due at 10 p.m. So make sure if you want full attendance credit, that you're also doing that facial bones test before 10 p.m. or at least starting it. I need to see that you've started it before then too, so I can give you credit. Okay. Any other questions? All right, I will go ahead and wrap it up for tonight. If you need to ask me anything, I'm available through email in case something goes weird, you can't access something. If you have questions on any of the assignments that we're doing, please don't hesitate to email me. I will try to get back to you as soon as possible. All right, have a good night, everybody. Thanks for joining me. I will see you tomorrow.
Bye.
Bye. Thank
Bye.
you.